Hi everyone, welcome to our webinar tonight. I'm so glad that you are here to join us. Thank you, Joe, for sharing the message with your big network. Um, we'll just give it a couple more, or maybe a minute or two, just to see if there's anyone else that's going to join. But yeah, I'm really glad that you've made the time available to join us tonight, and hopefully we can share some interesting information with you that can be beneficial. You're welcome to ask questions during Dr. Lize's presentation and during my presentation later. We'll start with her. She'll speak for about 45 minutes, and then there'll be some time for questions and answers. You're welcome to unmute and ask the questions yourself, or you can type them into the chat, and I'll ask the question on your behalf, and then she can answer that for us. You're welcome to post. Hi, Krista. You're welcome to, put in the chat where you're logging in from. And yeah, we're just very happy to have everyone here tonight. I know we have a lot to get through, so I don't want to wait too much time. So I am going to introduce Dr. Lize. We're very excited to welcome Dr. Lize for Nieuwkoop as tonight's presenter. Dr. Lize is a general practitioner, and she's a passionate advocate for metabolic health, dedicated to helping people transform their lives through the power of nutrition. After completing her MB-CHB at the University of Pretoria and further training with the Nutrition Network in therapeutic carbohydrate restriction, she founded Nieuw-Metabolism, a medical clinic that offers a holistic and sustainable approach to preventing and reversing chronic conditions such as diabetes, hypertension, obesity, and much more. With a wealth of knowledge and a passion for redefining healthcare through food and nutrition, Dr. Lize brings both her expertise and inspiration to our webinar tonight. So Dr. Lize, we're very grateful to have you here. Thank you for what you're about to teach us, and we look forward to hearing from you.
Thank you so much, Jen. Thank you for having me. Thank you for asking me to co-host this webinar with you. It's really an exciting event, and I'm very privileged to be able to sit next to you. Thank you for all that work that you've been doing in the field of nutritional medicine. And yeah, I really hope that through tonight's session and maybe even more to come, that we would be able to educate people and actually give them the knowledge to understand conditions and to understand what to look for, because knowledge is power. And essentially, we want people to take responsibility of their own health. And this is actually the only way to do it, through education. So I am just going to share my screen. I think you should be able to see that now. Am I correct?
Yes, we can see that. I just want to check if everyone can hear and see the PowerPoint that's being shared. You could give us a thumbs up. Thanks, Krista. Thanks, Mia.
Awesome.
Okay, go ahead.
Thanks, nice. Okay, yes, so like Jen said, my name is Dr. Lize van Nieuwkoop. I am a GP practicing in the far east side of Pretoria, and my absolute passion is metabolic health, and I have the privilege to apply metabolic health and nutritional medicine in my patients' care. It can be a challenging field, but I think that's what I like about it so much. The body has this amazing capacity to heal if you just give it the right tools. So tonight, I decided to focus my presentation mainly on polycystic ovarian syndrome. You are more than welcome to ask perimenopause or menopause questions as well. But these three topics are actually massive topics, and I don't want to do anything half. So if there is a need for another webinar to specifically talk about perimenopause and menopause, we can definitely get that organized, and we can go into that topic way more in detail then as well. Just before we start off, just remember that the purpose of this presentation is for educational purposes only. If you are wondering if this is something that you would like to apply in your life, trying to treat or going on a venture of diagnosing yourself with polycystic ovarian syndrome, please don't do it by yourself. Go see your healthcare provider and make sure to always get their assessment in as well. Okay, so this is for educational purposes only, and I do hope that everybody learns something, if it's either for yourself or for a loved one, or even in a clinical setting. I really hope that you take something valuable from tonight's session. Okay, so without any further ado, why are we discussing polycystic ovarian syndrome? So polycystic ovarian syndrome is very prevalent. It's actually the most common endocrine disturbance in women, and it involves multiple organs. But I think a big reason as to why it is a big topic is that it is a massive cause of infertility. So about 95% of couples who consult fertility clinics actually suffer with polycystic ovarian syndrome. And it is also a major reason why patients struggle to retain pregnancy. So people with PCOS usually have about a 3 times higher risk of miscarrying. But aside from the fact that it is actually a huge endocrine problem in women, it's not a new condition. So it's interesting that Hippocrates actually in 460 BC described manly women or women with male characteristics unable to bear children, which poses the question of, has polycystic ovarian syndrome actually been around for quite some time? But it has definitely in the past few decades become more prevalent, and that's got mostly to do with our Western lifestyle. So we'll delve into that in a bit more detail later on. So this slide is just to kind of give you an idea of how complex a normal menstrual cycle can be. So we need this fluctuation of different hormones in correct concentrations to simulate and to have normal ovulation, normal menstruation. So I don't want to confuse you with it, but just so you can see, it is quite an intricate a cycle. What causes polycystic ovarian syndrome? So the cause is not exactly known, but it is definitely a complex interplay between genetics. There's a strong genetic link, environment, and lifestyle. And this is the whole concept of epigenetics. I don't want to go into epigenetics, but what epigenetics basically means is that your environment, your lifestyle influences how your genes get expressed. Okay, so if you are interested in the topic of epigenetics, I highly recommend you getting the book of Dr. Ben Lynch, Dirty Genes. Really good, easy read if you want to see what epigenetics are. Okay, so but there's a very strong link, genetic link with polycystic ovarian syndrome. But other things like our low-fat, high sugar, high carbohydrate diet has definitely precipitated the problem in the past few decades, and we are seeing polycystic ovarian syndrome way more often than we used to a few decades ago. Okay, so the symptoms of PCOS. When should you consider PCOS? So usually it presents or it's associated with irregular periods, less than 5 periods a year, or a cycle shorter of 26 days or longer than 35 days. And this is usually from the time that you start menstruating. We call it menarche. Okay, so you have never had a normal cycle or a normal period. And then we have a lot of symptoms that has got to do with the overproduction or overexpression of testosterone in your body, which would include acne, obesity, male pattern hair growth, which would be essentially, we call it hirsutism, so a kind of a bit of a beard, a bit of hair beneath the nose and above the upper lip, you also might have a family history of somebody struggling with these type of symptoms, because there's this genetic link that we're talking about. And then acanthosis nigricans is a clinical sign, which I just want to show you guys here, indicating insulin resistance. So this is this leathery kind of pattern of your skin, specifically in your neck, underarms, sometimes on your elbow, and this is a good sign of insulin resistance. Okay, so if you are experiencing these symptoms, you might be considering to go have it diagnosed. So how do we diagnose this? This is the Rotterdam criteria that we call it, and you must have 2 of the following criteria to qualify as having polycystic ovarian syndrome. The first one is hyperandrogenism. So this is basically those symptoms I spoke about testosterone dominance. You have a high level of testosterone leading to those symptoms. Irregular menstrual cycles, which usually indicates irregular ovulation. And then on ultrasound, you have polycystic ovaries. About 80% of all PCOS is insulin driven. Okay, we do have some rarer subtypes like beta carotene and adrenal PCOS, but they are way less prevalent than the insulin driven polycystic ovarian syndrome. And qualifying with all 3 of these criteria means that you have the most severe form of PCOS, and you typically suffer more symptoms with the severe form of PCOS. So you go visit the doctor, and we do a few blood markers to see if we can find any evidence of that diagnosis. What would we do? So a big part of it is actually aimed at the metabolic dysfunction, which is caused by the raised insulin levels, insulin being the driver of polycystic ovarian syndrome. So with insulin resistance, you have a high fasting insulin level, and we can work out what we call the HOMA-IR index, which would indicate if you're insulin resistant or not. Some ladies have an abnormal oral glucose tolerance test. This is a test where you ingest a certain amount of sugar, and we test your blood sugar level after 1, 2, and 3 hours after ingestion. And if you are insulin resistant, you will typically struggle to put sugar away. Okay, so you wouldn't have optimal sugar metabolism, and essentially we can diagnose insulin resistance like this as well. Then HDL is our good cholesterol, and that tends to be low. HDL of 1.3 is the minimum of where it needs to be for women in general. And why HDL is low in polycystic ovarian syndrome is actually quite simple. It's a pro-inflammatory state due to the high insulin levels chronically. And what HDL needs to do, it needs to try and clean up damage. So you kind of run through your HDL stores while you are in this inflammatory state. So people with PCOS tend to have a low HDL level. And conversely, they have a high triglyceride level. Triglycerides is also a fat. It's not a cholesterol in and of itself, but it's a fat that we test with the cholesterol panel. And this is actually a very sensitive marker to cardiovascular disease in long term. And I think the most important thing is actually having the ratio between the HDL and triglycerides being unfavorable, meaning that your triglycerides are always higher than your HDL level. You would be a high risk candidate for cardiovascular disease in the long term. So ideally, we would want to flip that ratio around, have your HDL higher than your triglyceride level. Then with physical examination, obesity and increased waist circumference is a big sign as well. Serum testosterone levels, we'll delve into that a bit later, where I just describe why testosterone is high in polycystic ovarian syndrome. We tend to have a low sex hormone binding globulin. This is a protein that essentially binds testosterone to leave it inactive inside of the body. So insulin, because of the fact that insulin is so high in insulin resistance, this has a negative effect on your serum sex hormone binding globulin. So this leaves testosterone even more active and prevalent inside of your body. And then it's important to do your TSH, which indicates your thyroid function, just because an underactive thyroid can mimic a lot of these symptoms of PCOS. So you need to be sure to be looking out for any other possible diagnosis that can explain your symptoms. Other useful markers would include your fasting glucose levels and your HbA1c. As polycystic ovarian syndrome patients tend to be at higher risk of developing metabolic disease, of which diabetes is a big part of metabolic disease, essentially. And then the last one that I always like to include there in as well is your high sensitivity CRP. This is a very sensitive marker for underlying chronic inflammation, which would also, in a setting of insulin resistant, be high. Okay. So the next thing after we did our blood test is we basically would need a sonar to get the ovary part diagnosed of it. So what is considered to be a polycystic ovary? This is an ovary where there's 12 or more follicles measuring at least 2 to 9 millimeters, and then or a enlarged ovary of more than 10 centimeters, and it may only be one ovary, although it's rare. It's usually both ovaries that is affected. So let's just delve into this whole testosterone or high testosterone level and the symptoms that it causes. So androgens are basically the male sex hormones, of which testosterone is the most common one. But androgens are also produced in our ovaries and adrenal glands of women, but most predominantly in the ovaries. Okay. Overproduction of testosterone will lead to signs of androgenism, which we mentioned, that male pattern baldness, hirsutism, which is facial and body hair, acne, low tone of voice, irregular menses, and in very serious cases, clitoral enlargement. But why? Why is testosterone so prevalent or so dominant in a polycystic ovarian syndrome? It's because of two mechanisms, essentially. And I don't want to confuse you guys too much with this slide, but I want you to see and appreciate that estradiol essentially is derived from testosterone. And this process is done by aromatase, which is an enzyme that is inhibited by insulin. So if you have high insulin levels, which is the driving factor of polycystic ovarian syndrome, then we are going to inhibit the function of aromatase, which means that we are basically going to have this buildup of testosterone in the background. And this is why we have testosterone predominance. And another reason for having the testosterone predominance is actually that the ovaries itself also has insulin receptors. So they are very active in producing their hormones because insulin is constantly motivating them to do so, if I can put it that way. So another symptom is the irregular menses. About 85% of all polycystic ovarian syndromes will actually have menstrual irregularities. And what this usually signifies is irregular or absent ovulation. And this is where the infertility part of polycystic ovarian syndrome actually comes from. It's not impossible, though, to have normal menses and still be anovulatory, okay, although it is rare, okay. So in most people, having irregular cycles is an indication of you either not ovulating at all, or ovulating in a very haphazard, unpredictable pattern, not the usual between 26 to 35 day cycles, okay. Like I mentioned, you can still have regular cycles and still be anovulatory, although this is not the most common thing. And this is the reason of the infertility that we see in polycystic ovarian syndrome. Basically, the polycystic ovaries it's fairly simple to visualize. Actually, is follicles are the cells that contain the egg cell. It is what is stimulated by the hormones to mature in a cyclical pattern. And eventually, through that whole complex hormonal slide I showed you guys in the beginning, eventually reach a point, 1 or 2 follicles at a time, usually, to ovulate. Then they involute again, the immature follicles, basically. So what happens in polycystic ovarian syndrome is that because of the insulin receptors, the ovaries being very sensitive to insulin and testosterone, it goes in this overdrive of actually producing follicles. So we have more than the classical 1 or 2 follicles moving into maturing. But then why? What happens to the ovaries or the cysts that is busy maturing? Is basically the insulin also leaves these follicles more sensitive to LH, which I actually just want to jump to that slide to show you guys. So LH is this green hormone, and insulin leaves the ovaries more susceptible to LH, and it means that the follicles respond very sooner than they should to the LH surge, and then they didn't reach full maturity to be able to ovulate. Okay, and that means that we have this ample amount of immature follicles that is unable to ovulate and just kind of hanging around there, and that's why cysts actually stay behind. So typically, PCOS is where there's 12 or more cysts. I've mentioned that. We can go into detail. Smaller cyst usually shows a bit of a androgen predominance, and larger cysts more of a fasting insulin predominance. But that's not really important to distinguish between the two. But it is important to understand that there are multiple or other conditions that you can have cysts in your ovaries and you don't necessarily have polycystic ovarian syndrome. So in the absence of the symptoms of high testosterone levels and in the absence of irregular menstrual cycles, you would not be classified as a polycystic ovarian syndrome. Okay, so what if it's not PCOS and you have some of these symptoms? What could it possibly be? Pregnancy would be a big one, one of them, which you definitely need to exclude before moving on for the diagnosis of polycystic ovarian syndrome. Then we've got 2 conditions that's got to do with hormones as well, or actually 3 conditions: the hyperprolactinoma, Cushing's syndrome, and the thyroid disorders. All of these disorders can mimic the same symptoms. And we need to make sure to just look at these conditions and try and see if there's another explanation for your symptoms. Non-classical congenital adrenal hyperplasia, that's a mouthful. Very rare condition, but this is where the glands on top of the kidneys are also essentially malfunctioning and also causing a havoc in hormone production, which can also mimic these type of symptoms or produce these type of symptoms. And then essentially anything that would cause you to have a high testosterone level inside of the body can obviously also produce a lot of these symptoms. So this could be drug induced. People maybe in the bodybuilding world using testosterone for their physique. We may be having ladies using testosterone for poor libido. And a lot of times, cancer treatments and anti-estrogens and all of those type of things that we use medicine-wise can also cause a testosterone predominant type of picture. So it's always important to just, when you go to your physician, having all of these questions, to take a list of all the supplementations that you are using, all of the medicines that you are using, so that they can try and distinguish what might be a side effect from the supplementation or medication and what might be a primary medical condition. Okay, so why is it important to know about polycystic ovarian syndrome? I think the big focus of PCOS in the last few years have obviously been in the area of it causing being a big cause for infertility and recurrent miscarriages and all of that. And that's a very important topic, and it needs to enjoy all of the attention that it has been getting, because infertility is a major reason of ample amount of despair in people's lives, and we need to focus on that, absolutely. But I think for me, if there's one thing that you take home from this presentation, is to understand that there is, due to this high insulin hormonal state, there is metabolic dysfunction in the background, and it will never leave you. Okay, so it's not just in your reproductive years that you'll be experiencing metabolic dysfunction. It is actually throughout your entire life, even going through perimenopause and postmenopause. So ladies suffering from polycystic ovarian syndrome are at higher risk of developing metabolic syndrome, which will obviously affect their long-term health. So things like blood pressure, obesity. I've mentioned that triglyceride, HDL, and maybe an unfavorable ratio of those two, leaving you more susceptible to cardiovascular disease in long term. Diabetes, stuff like gout and depression. Depression and anxiety is a big one, because chronic high insulin levels is very neuroinflammatory and is associated with a lot of treatment refractory depression. You can possibly be higher. People with metabolic disease is higher risk of developing cancers, as they are developing osteoarthritis as well as gastritis. General fatigue, malaise, brain fog, all of these signs are basically signs of sustained systemic inflammation, migraine and headache complexes, leaky gut, which is basically chronic inflammatory condition of the gut causing systemic inflammation, leading to malabsorption. It's just this whole havoc that can be happening inside of your body. And we need to make sure that people diagnosed with polycystic ovarian syndrome understand that, aside from the fact that it might be difficult to fall pregnant and retain pregnancy, they need to understand that this has real implications for their health in the long term. And the faster they actually actively try and treat the metabolic dysfunction, the better in terms of their long-term outcomes and health. So people with polycystic ovarian syndrome also are at increased risk of complications during common illnesses. They have a higher risk, a higher rate of hospitalizations during pneumonias or common infections, and they have a higher risk of complicating post procedures as well. So this is all just signs of overt metabolic dysfunction in the background. And unfortunately, everybody with polycystic ovarian syndrome needs to be cognizant of it and apply active management to try and lessen their risk for these health complications long term. So why insulin? Why does insulin have this massive impact on ovaries and PCOS and all of that? And this has actually been described in the 1980s already, where they noticed that insulin has this effect of overproduction of testosterone in those two mechanisms that I mentioned, of the aromatase being inhibited by high insulin levels, leading to the fact that testosterone cannot convert to estradiol. And the second thing is that sex hormone binding globulin that's also lower in high insulin states. So the sex hormone binding globulin cannot bind to testosterone to leave it inactive. So then we have this cumulative hyperactive testosterone environment, essentially. And this is why insulin has this big impact on our ovaries and why it's the driving factor of polycystic ovarian syndrome. Just quickly, how does the infertility come about? I did mention this earlier, is where your immature follicles react towards testosterone, and it helps, or it kind of stimulates the development of multiple follicles. But then why ovulation does not occur is because insulin leaves these follicles very sensitive to LH, and they kind of react too soon to this LH gradually going up, and none of the follicles are mature enough for ovulation, and after they react to the LH kind of stops any further follicle development, meaning it has an inhibitory effect, stopping it from actually reaching maturity. And then we just have these multiple fluid-filled sacs that we can see as cysts on the ovaries. So essentially, insulin is the bad guy in polycystic ovarian syndrome, much like it is the bad guy in metabolic syndrome. So what can we do about it? I think that's the big question, and it's never an easy answer, in my opinion. Every patient's needs are different. Every patient's circumstances are different. So I think the big question is, what's the aim of you going to the doctor and asking for help? What is bothering you, and how much time do we have? Essentially, if you are 21 years old and you have very irregular menses, maybe have a bit of male pattern facial hair, and that bothers you, and you do not necessarily want to fall pregnant anytime soon, I would say that we have some time. Whereas somebody who's 33 years old, who has been trying to fall pregnant for the past year, coming into the infertility clinic or gynecologist's office, asking what's going on, I would say that we maybe have less amount of time. So it really just depends on the clinical setting and the patient of what we should do. But essentially, we have a lot of infertility treatments, which is not the focus of this talk, but there are great medicines and treatments and programs that can help people with polycystic ovarian syndrome fall pregnant and also retain pregnancy. One of the big guys that is kind of used as first line is metformin, which is the common, I want to say, anti-diabetic drug, but actually what it is a insulin sensitizing drug. So essentially, any drug that's going to drop your insulin levels, or any method that's going to drop your insulin levels, will increase the chance of you retaining a normal cycle and ovulating again, falling pregnant, and getting rid of these, let's say, testosterone dominant symptoms. So metformin is the big one. We have a lot of other medicines there. We have oral contraceptives, which obviously would not work if your goal is to fall pregnant, but if it's just for menstrual regulation, it works well. And then we have over-the-counter type of things that I want to say are supplements, but they work well in terms of sensitizing your receptors towards insulin again, and trying to drive insulin levels lower. So we would aim to reduce testosterone predominance in patients with PCOS. If we have time, though, I would highly recommend that you would do a possible combined approach between something that helps you with insulin sensitization, something like Procositol and Insucu Max, and combine it with an appropriate diet. So what would an appropriate diet be in a high insulin state? That would basically be a very low carbohydrate diet, ketogenic if you can. I'm saying it's not possible for everyone. There's certain circumstances where I would not recommend a patient to go into ketosis yet. It might change after 6 months of them being on a low carbohydrate diet, on a bit of glucophage to help drive the insulin levels down a bit. But essentially, a very low carbohydrate diet is a low insulinogenic diet. And it's a sustainable diet as well. If you are somebody who really wants to go for it, then you can definitely consider doing intermittent fasting or time-restricted eating, because we basically have an insulin response when we eat, irrespective of what we eat. Okay, so you may be sticking to a very low carb diet, but if you have frequent meals or frequent snacking in between, you will have some sort of an insulin response just by the act of eating. So intermittent fasting and time-restricted eating is a really nice tool to really drive those insulin levels way, way, way down. A very low carb or ketogenic diet would be high in natural fats, which would be so important, especially for that part of the HDL. HDL, there's no way that you can replenish your HDL, your good cholesterol, besides eating good, healthy, saturated fats. And if you have nice ample amounts of HDL, you are going to be able to clean up systemic inflammation easier. And then the last pillar of treatment is all things essentially that contribute to systemic inflammation needs to enjoy attention. So exercise is a big one. Sleep hygiene, so important. I think a lot of people just struggle to lose weight, struggle to get rid of their insulin resistance, struggle. And when you go back and actually try to see how their sleep patterns are looking, you can find the answer there. We tend to have very hectic, busy, stressful lives that affect our quality of sleep so much. And it's a big part of you being able to control systemic inflammation. So that's a big one to look out for. And then other things like food sensitivities can also be a source of chronic gut inflammation, which would lead your insulin levels essentially to never really fully go down, and you being able to take control over this metabolic dysfunction. So just in a nutshell, I want to say the low carb, high fat diet and way would be the lifestyle of choice in terms of treating polycystic ovarian syndrome, coupled with appropriate insulin sensitizing drugs when deemed appropriate. I just want to mention here that people tend to think that a ketogenic diet is a high protein diet. It's not necessarily, it's not meant to be that. It's actually a high fat diet with moderate protein intake. And why is it important to stay with a moderate protein intake? Is because protein also has a effect on glucose. We do have a bit of a glucose response. It's about a third of what a carbohydrate would give you, but there is still a bit of a blood sugar response on a protein intake, of which there's virtually no response on intake of fats. So that's why it's actually a high fat with a moderate protein diet. Very important to skip the snacking. Like I mentioned, the act of eating will have some insulin reactions, and then fasting would be a very good tool to try and drive those insulin levels down. So I think also just the last point I really want to emphasize here is it's okay to take things slow, because essentially if you revert back to old ways, you will become metabolically unwell again. So I think the big thing for me is always sustainability. I can always advise a patient to do A, B, and C, but if it's not sustainable for them, it will not lead to them actually being able to look after their health long term. But also just to remember that it's a dynamic process. I might suggest that you go just on a low carbohydrate diet, avoid ketogenic diet, maybe just because I see that you have a very carbohydrate rich diet and really think that you're going to struggle on a ketogenic diet in the first few months. And by the time you come see me at month 4, you actually reverted to a ketogenic diet yourself. So it's not the plan that we instill or have for you today in the beginning is not necessarily the plan that you're going to stick to for the rest of your life. Although we will stick to low carbohydrate, low insulin principles, and basically take it from there and take care of your health and take care of your metabolic function overall. So yes, that's basically it. That's my presentation for today. There's a few of my contact details if you would like to get into contact, ask a few questions, maybe get a metabolic health assessment done to see where you are at, so we can get you going to better health and a better metabolic function. Thank you so much. Any questions?
Lize, that was so helpful. If you want to ask, just raise your hand and then I can and unmute. But I just want to say, thank you so much for that presentation. I wish that I knew all of that information 10 years ago when I was struggling with my fertility issues. And I was grappling at information and none of it really made sense. I wasn't the classical polycystic ovarian looking person. And so I didn't think I had it. And only when I actually started cutting out the carbs and lowering my insulin did things come right. And it's come right even more since then. But yeah, I think this information we're not aware of. And then we turn to medication and drugs and other ways to try and solve our problems, but it doesn't actually solve anything. So thank you.
Yes, no, definitely. I agree with you. Medications help a lot. And in terms of fertility as well, I think if your goal is to fall pregnant as soon as possible, do not avoid it at all. But just to realize that, your end goal might be pregnancy and a baby, but remember that you still have PCOS and it's going to leave you susceptible to other health risks. And there, I would say, in terms of sustainability, medication, I wouldn't say it's not appropriate, but it won't be my appropriate first line. I would say let's do the basics right. Get you on a low carbohydrate diet, get your insulin down as much as we can, and then use medication when appropriate and indicated.
There's a question from Audrey. I'm just going to read it out loud. She said, thank you so much. It was brilliant. Do you have any experience or information on near-infrared or photobiomodulation therapy? I know it is a new up-and-coming treatment as well.
I do not. I'm going to have to come back to you on that. I do not have any new insights on that topic.
Audrey, I think the whole role of infrared is that it stimulates mitochondria to function better. So overall, if you use it and your cells start working better, they will respond better to the environment that you give it. So I know when I was having my natural treatment for polycystic ovaries, they did use the infrared specifically. At the time, I didn't know what it was for. Probably also decreasing inflammation. Okay, cool. Yeah, well, let's find out about that.
Can I just comment on that? Is in terms of mitochondrial function, the big thing is, will you be able to sustain these type of therapies? And that's the big qualm I have with using things and using medications or using supplements instead of just going back to the basics. So I would say, if you have somebody in your offices and you know that they're having poor sleep, maybe they're perimenopausal or in menopause, they're having really bad hot flashes that keeps them up at night. All of these things are basic things that we can try and change and try and address in the long term. And then when you do not reach success with the basic adjustments in terms of diet and lifestyle, stress management, and all of those type of things, and you do not get rid of your systemic inflammation with that, then I'm an absolute fan of going for supplements, going for treatments, going for all of these type of things. But I just have a bit of an issue where people might feel like, I'm suffering with PCOS or I'm suffering with metabolic dysfunction because I do not have access to these treatments because I do not have access to these devices. And that's not true. You may benefit from it, but are you going to be able to continue with this for the rest of your life to basically retain your health? And probably not. So I think the focus should shift more on essentially what are you doing wrong fundamentally. We try to fix that first, and then we run to therapies and supplements and medicines, essentially.
Any other questions? Yeah, the habit is the way to go. And I think, as you say, we need to address the underlying causes, the root causes, before we try and put all the band-aids on top. And if we don't address the root cause first, we're never actually going to improve what's really driving the problem.
Absolutely. And I think the big frustration is it's definitely not an overnight fix. We live in a world where we want instant results and we want instant fixes, and it just, in terms of health and longevity, that just it does not exist. So if you come sit in front of me and I point out that you possibly have 16 things that we need to address, you're gonna feel overwhelmed. You're gonna probably say after about 2 or 3 weeks that this is not for you and give up. So I usually try to simplify things, address the big issues first, and if we do not get the results that we want, we go into a deeper delve.
Thank you so much, Lize. We really appreciate that. Thank you for your time and all your effort in putting your presentation together. It was really, really helpful.
Thank you so much for having me.
Sure.
I'll be here as well for questions at the end of your session, Jen, if anybody can think of another question they want to ask.
Great, thank you. Okay, so in the meantime, I'm going to share my screen with you, and you'll see a QR code. If you would like to, you can take your phone out and just click on that QR code. In the meantime, it's for Slido, so it is going to be a bit of an interactive presentation, and I'd like to hear some of your feedback and get some of your not questions, but your information as well while we're doing that. So I'll just give a couple of minutes to do that. I'll also put it in the chat notes in case you can't access your where is it now? In case you can't access the QR code. There you go. Okay. It will come up again. So can you all see you can see the slide. Thank you, Krista. So we're going to be discussing a little bit more in detail about hormones, brain fog, and weight gain, why all of this happens. And it was so interesting to have Dr. Lize's presentation before, leading us up to the big insulin factor, which is really the underlying cause of all metabolic conditions. And by trying to reduce insulin is how we're going to treat the root cause of all of these conditions. So why me? My name is Jen, for those of you who don't know me. I'm an occupational therapist. I'm also a woman who's 41 years old. And I've been working in my own occupational therapy practice for almost 20 years now, mostly in neurological rehabilitation. And I've had a very strong interest in brain health and neurodegenerative conditions, dementia, and stroke. And I think what brought it all together for me was just realizing that ultimately all of the clients that I was seeing in my practice had some form of metabolic syndrome that was affecting their function. And by the time they got to me, they'd either had the stroke or they'd had the heart attack, or they were not functioning properly at work and had to be medically boarded and needed an assessment. And so that really led me down a path of learning more about metabolic health and how I could really use this knowledge to address it in my clients and help them to recover better from a more holistic point of view. So I developed an interest in metabolic health and disease prevention, and last year I became certified as a nutrition network practitioner through the Nutrition Network. I've also built a community of people over the past year that supports each other in making lifestyle changes. And what really drives me every day is to help women to feel more energized, to help them lose weight, improve their sleep, improve their brain health, and boost productivity at work. So this is just a little bit about me. That was me on my graduation day when we got to show off our certificates and be welcomed by actually Professor Tim Noakes as part of his Nutrition Network practitioners. I have got 2 children, Holly and Rowan. They are 10 and 5, almost turning 6. We like going camping and spending time outdoors. And I've also recently taken a big interest in doing CrossFit over the last maybe 3 years, and definitely been improving my skills there. But this was me in my early 20s. And like I said earlier, I was diagnosed with polycystic ovaries it was actually in my late 20s when we were starting to try to start our family that I found out and was diagnosed. But I think looking back, it was something that had been with me for a long time before that. And these photos were actually taken soon after I finished school. So I probably wasn't even 20. I was 18. I'd moved to Australia to go and do a gap year there, and the food was very different. I suddenly switched from what I would normally be eating to a very high carbohydrate diet, lots of bread and sweets and desserts. And we lived in a boarding house, and there was just always food around. And so I gained weight very quickly. In a short space of time, after being someone that could kind of eat whatever they wanted and never gained weight. I didn't know at the time, but I know now that I was insulin resistant. After gaining the weight, it was difficult to lose it, and I kind of felt like I had that muffin top with the weight accumulating around the belly. In terms of my cycles and polycystic ovary symptoms, I had spotting instead of actual bleeds. I had very long cycles, longer than 35 days, and sometimes they were a couple of months. I wasn't ovulating, and it was very difficult to pinpoint when ovulation was occurring. So to try and fall pregnant when you don't even know if you're ovulating was very difficult and frustrating. I wasn't making enough hormones to support my reproductive cycle. And I then had reduced fertility, went to see the gynae, and they put me on Clomid to help me ovulate. But I realized that that wasn't the right approach, because if my body wasn't ready to accept an embryo or a fetus or even ovulate, then it definitely wasn't ready to sustain a pregnancy. And so after that, we had a miscarriage, and then I decided I'm not going back to the gynae, and I found a natural homeopath who assisted me to fall pregnant with Holly by changing my diet and doing some other alternative therapies. And then the same again with Rowan to fall pregnant with him, which was they're 4.5 years apart. And only really since Rowan was born, and I'd say in the last 5 years, have I really taken a deep dive into nutrition and realized that I was insulin resistant all this time, because I felt like I never quite fit into any of the boxes that they always say about the reasons for polycystic ovaries. And so since changing my diet completely and using a low carbohydrate approach, I've managed to reverse the insulin resistance and basically reverse my polycystic ovarian symptoms. And I now have regular cycles that are within a normal range of time, very consistent. So all of those symptoms have gone away. And so for me, that was just so mind-blowing that something as simple as diet made such a big difference in my body and in my life. So if you manage to click on that link, the slider link, I'd like you to open up your phone now and then just type in, what do you feel your biggest health challenges are right now? And we'll see everyone's answers popping up on the screen once they come through. You can still join by clicking on the QR code. Yeah, fertility is a big one. Losing weight around the belly. Brain fog. The weight loss, energy, joint pains, also huge inflammation driver behind that, and the brain fog, it's brain inflammation. Okay, keep them coming. Sleep problems, stress, thyroid, focusing. Okay. So I think a lot of us are struggling with similar issues. And as women, as we get older, these problems start to creep up on us, and we start to think it's because I'm in my 40s now, or I'm heading towards menopause, that all of these symptoms start to come up. So you can keep typing, but I'm going to change the slide. I don't know if it will turn it off. So what if this isn't just about getting older? So one of the biggest lies out there is that all of these symptoms that we've just described are just part of getting older, that they're normal, and that as women, we should expect them as we get into our 40s and towards 50s. And it's so common to hear things like, well, I'm just not 25 anymore. This is what happens when we age, what runs in my family, and we all deal with this eventually. But the truth is that all of these symptoms are not about age. They're your body's way of waving a big red flag and telling you that there's something wrong, that something isn't working. And we've been taught to just ignore these problems or symptoms, to push through, or to grab the quick fix for temporary relief. But every time that we do this, we're not solving the underlying problem. We're just masking it. We're putting a Band-Aid over it and hoping that it will go away. And eventually this leads to bigger issues like diabetes, autoimmune disease, cancer, and even Alzheimer's disease. And I think polycystic ovaries is one of those signs that your body is not functioning properly. And we get that at an early age because it's during our reproductive years. And a lot of the time it's masked by being on the pill. And I think for me, for 10 years, I didn't know I had it because I was on the pill, and I just didn't know that I was having abnormal cycles. But if we see that as a sign that our body is not well, we need to do something to change that. And if we just continue, that underlying metabolic dysfunction is still there, and eventually it will lead to issues like diabetes or pre-diabetes and weight gain and all the other problems that come with metabolic syndrome. So according to the WHO, the main issues that women are facing in 2025 is a huge metabolic health crisis, hormonal disorders, and mental health and stress. And I think all of those symptoms that you just described clearly fit into one of these three categories. And as women who are still working and raising a family and trying to be healthy and exercise, there's a lot of stress and a lot of disruption in our health. Okay, so the next poll is, what are the main diseases affecting women in 2025? So you can just put this in order or pick which one you think are the main ones that affect women, because a lot of the time we think some diseases are more affecting men and that women are immune from them. So have a go at that one. And while you're doing that, I'm just going to read this, that at a global level, 7 out of 10 causes of death in 2021 were non-communicable diseases. That means diseases that are not infectious. And that accounted for 38% of all deaths, or 68% of the top 10 causes of death. And these are preventable diseases. And actually, as a government and as a country, we need to be doing more to prevent these chronic diseases instead of just trying to manage them, but actually people are just getting more and more sick. So interestingly enough, women are just as prone to dying of heart disease than men. And as our metabolic health worsens, we're actually more at risk of heart disease than men. Stroke is another leading cause of death in women, which is also a metabolic condition. Chronic obstructive pulmonary disease is up there. Trachea, bronchus, and lung cancers, breast cancers, and maternal conditions. So all of these conditions definitely play a big role, and we've put depression on top. I think depression definitely affects women hugely in today's day. So what are we doing? Well, why is what we are doing, why isn't it working? If we look at this graph from 2019 up until going towards 2040, we can see that comorbidities are rising, depression is on the increase, diabetes is very much on the increase, and heart disease is also going up. And those are our non-communicable diseases. Now, we're all following the guidelines that have been told to us by the government of how to eat healthily, what we should be doing, what we should be avoiding, how much exercise to do. And yet we all just feel worse and worse. We're gaining weight. The obesity rate is massive and it's not getting any better. And when I work in the hospital, I just see all these very sick patients that are just not getting better, even though they're under the best medical care. So one of the big drivers of this is the diet heart hypothesis, which was introduced in the 1970s in America by Dr. Ansel Keys, and he was the scientist that told everyone that saturated fat caused heart disease, and the American government then took that and decided to make saturated fat the devil and evil, and told everyone to eat a low-fat diet and avoid saturated fat because it caused heart disease. Well, we know now that, and the reason behind that was that they assumed that consuming certain dietary fats, like these saturated fats, raised blood cholesterol levels, which then led to a buildup of plaque in the arteries and resulted in heart disease. And their advocates was then to tell people to not eat a high-fat diet and to rather eat a low-fat diet. They also recommended replacing red meat with plant-based proteins like lentils and beans, and eat plenty of fruits and vegetables, lean proteins, and whole grains while limiting saturated fats, processed foods, and sugar. So that's one thing. But then by removing fat from the diet, we had to get our energy from somewhere else. And so the energy then came from carbohydrates, and we were encouraged to eat a high carbohydrate diet. The calories in, calories out tell people that weight change is determined by the balance between the calories that you consume and the calories expended, which is not true. So the calories in a whole food is definitely not equal to the calories in a highly processed food. And we can't just exercise our way out of to lose weight. Constant hunger and cravings lead to overeating, unstable blood sugar, and overproduction of insulin. And also modern foods are designed in laboratories where they are scientifically engineered to be addictive and highly palatable, leaving us unfulfilled and wanting more. They don't actually fill us up, and they don't give our bodies the nutrition that our bodies need in order to work properly. So basically, it's your metabolism that is broken, not you. And so often women are led to believe that they are broken, they aren't working properly, their bodies are dysfunctional. But it's not that at all, it's our metabolism. So I'm going to go into a quick Little description about what we choose to fuel our bodies with really does matter. And in this graph, you can see that we have three main fuels that we can use for our body, and those are carbohydrates, protein, and fat. When we burn carbohydrates, we actually use them first before we can burn any of the other fuels for energy. They give us a quick spike in energy, but they don't last very long. So if we're looking at our glucose levels, if we eat a high carbohydrate meal, our blood sugar will go up quite significantly, and then it will come down quite quickly after that. And I always describe it to people, it's like burning pine cones in a fire. So they burn up quickly, and we have to keep replacing those pine cones if we want to keep the fire burning. Protein is not really a fuel, but it can be used as a fuel, but generally it's broken down into amino acids, and it accounts for minimal energy in the body, but it can last for up to 4 hours. And as Lize said, as she mentioned earlier, fats, energy or the fuel that we can use from fat starts out more slowly, but it lasts the longest, and it's the most sustainable form. So when we're talking about carbs, what exactly are we talking about? And here's just a quick diagram for you to see the amount of carbohydrates in each of these foods per 100 grams. So even your high sugary fruits like bananas, pineapples, and mangoes, they contain quite a significant amount of carbohydrates. Your rice, bread, pasta, potatoes, juice, and chocolates, they're all very high in carbohydrates. And as we've spoken about before, insulin is the driving hormone that signals inflammation in the body. So we need insulin to allow the glucose that is in our blood to be absorbed into our muscles and in our liver for storage. But if we have too much insulin in our bodies all the time, it can be inflammatory and damaging to all the organs that it comes into contact with. So insulin is a hormone produced by the pancreas that helps to regulate blood sugar levels. It allows cells to absorb glucose from the bloodstream to be used for energy or stored for future use. Hyperinsulinemia, that's too much or more insulin in the blood, occurs when the pancreas produces too much insulin. And this is often a response when we have insulin resistance, where the body's cells become less responsive to insulin's effects and force the pancreas to produce more insulin in order to maintain the normal blood sugar levels. So before we even get to being diagnosed with diabetes or pre-diabetes, what's happening in the background is that your body is having to produce more and more insulin in order to keep your blood sugar levels within the normal range. And over time, that stops working, and we then start to see that the blood sugar levels are creeping up, and you would get diagnosed with a condition like pre-diabetes or even diabetes. So while hyperinsulinemia is often associated with insulin resistance, it is important to note that it's not synonymous with diabetes, but it can lead to pre-diabetes and eventually type 2 diabetes if it's left unmanaged. And hyperinsulinemia is caused by insulin resistance, but also has several other factors that can contribute to this condition. And then we spoke a bit about insulin resistance. So that's when the cells stop responding to the insulin signal, and then the body has to make more and more insulin in order to get that sugar to go out. And over time, this leads to chronically high insulin levels. And the other thing is that insulin is a storage hormone. So it's something that if we need to store energy, then we make a lot of insulin. And so when we have high insulin levels, it becomes very difficult to burn that stored energy, which is the fat, because it's locked away by insulin. So now looking at this graph, which is similar to the previous one, except now we're looking at the effect on insulin when we eat different foods. And we can see that when we eat a high carbohydrate meal in the red, we need a lot of insulin to bring that sugar level back down to baseline levels. With protein, it's not quite as high as the carbs, but we still do need a bit of insulin to bring it back down again, especially if it's pure protein on its own or lean protein. And in the blue line, fat requires the least amount of insulin, and it also brings that insulin back down to baseline levels much quicker than the carbohydrate meal. And so what does all of this matter? So when we have chronic high insulin and we're eating a high carbohydrate diet and we're eating all the time, 6 to 8 meals a day in some cases, we start off our day with coffee and a rusk or a sugary cereal or whatever it is, a fruit and yogurt, and that insulin just keeps rising and rising throughout the day. So if we look at the line at the bottom, which says carb addicted adult, this is someone, a typical person eating a standard diet, they're eating multiple times a day, and their insulin level is getting higher and higher and staying high throughout the day. And then it returns to baseline when they're fasting overnight, and the next day they go through the same cycle again. And that really drives this high insulin levels constantly in the body, or the chronic hyperinsulinemia. If we compare that to the ideal eating pattern at the top, where we eat 2 small or 2 meals a day that are predominantly protein and fat, we don't get the spike in insulin as significantly. And with the no snacking in between, it allows that insulin level to come back down to baseline levels in between meals. And if you're wanting to do intermittent fasting, you can see that the longer you then give space between the meals will mean that the more time you have without having to need insulin to bring that blood sugar down. This is a really nice graph that I like to show people. That's funny. And it shows the effect of glucose and insulin on our stress hormones. So when we experience stress and anxiety and that feeling of hangry and weak, sweating, palpitations, you know the feeling where you just have to get something to eat. Often the reason for that is that you've had something that shot your blood glucose levels up a few hours before, and you've got a good, strong insulin response. So with that, in the dotted line, you have this, well, the dotted line is insulin. So you've got the spike in glucose, you've got the spike in insulin, you feel great, got lots of energy. And that insulin causes the blood sugar to come down too quickly. And what happens then is that the body senses that the sugar levels are falling rapidly, and they can't let it fall below a certain amount because the body works very hard every day to keep the blood sugar within a very narrow range. And so when it senses that the blood sugar is dropping too quickly, it then signals a stress response in the body, and it secretes adrenaline, cortisol, and glucagon back out into the bloodstream to convert all the stored glucose that we've had in our muscles, glycogen. We convert that back into glucose and pump it back into the blood to raise our blood sugars. And just that is a stress response in your body. So never mind the stress that we go through on a day-to-day basis in the traffic or at work or with our families, but internally our bodies are facing the stress every time we're eating a high-carb meal and our blood sugars are dropping too quickly and then having to come back up again. So all of this chronic inflammation drives chronic disease. So we're eating a high-carb diet, it increases our insulin levels. High insulin also drives high cortisol, which is our stress hormone, either through that response there or just in general. High insulin is inflammatory and it causes high cortisol levels. This locks away our energy as fat. So we feel depleted and we're not able to use the energy that we've got. We gain weight, we want to eat more carbs, and it just drives a vicious cycle that leads to chronic disease and metabolic syndrome. So how does this all relate to perimenopause and menopause? So all of these symptoms that we experience when we start getting into these stages of life as a woman is that weight becomes harder to manage. We get weight around the middle, hot flashes, brain fog, restless sleep, all the symptoms that we mentioned earlier in the presentation. And none of this is in your head. They're all real symptoms. And the thing is, changes in hormones, inflammation, and your metabolism are all at play and all cause these symptoms. So while we can't necessarily change our hormones, we can change how we eat and move. And as estrogen declines with age, it also changes how our bodies store fat and how sensitive we are to insulin. Lower estrogen levels often means more insulin resistance, which makes it harder for the body to handle carbs and sugar without storing them as fat. Stress, poor sleep, and a slower metabolism also add fuel to the fire and increase inflammation in the body. So as the estrogen levels decline as we head towards menopause, we then become more insulin resistant if we weren't insulin resistant before. And that's why we often find that people in their late 40s or 50s start struggling with losing weight when they didn't maybe have that as a problem beforehand. So estrogen changes the way that we make and use insulin. Okay, so estrogen is one of the main female hormones, although men do have estrogen as well, and we, of course, do have some testosterone as well. It's mainly made in the ovaries before menopause, and a smaller amount comes from the adrenal glands, which are the tiny glands above your kidneys, and from fat tissue. During perimenopause and after menopause, when the ovary is producing eggs, the body relies more on the backup. Sorry, I think they should say when the ovaries stop producing eggs, the body relies more on these backup sources, the adrenals and our fat tissue, for estrogen, but they only make small amounts of estrogen. And that's why we notice this decline in estrogen. So estrogen is a master controller, and it talks to many different parts of the body. It helps to control the menstrual cycle and fertility. It keeps bones strong, supports the brain, protects the heart and blood vessels, keeps the skin, hair, and joints healthy, maintains the lining of the vagina and the bladder, and it also affects metabolism, body fat distribution, and even how sensitive we are to insulin. So when we start getting into perimenopause, our estrogen levels swing up and down like a roller coaster. And that's why women may feel very unpredictable symptoms, like hot flashes one week, mood changes the next, and then nothing. During menopause, because estrogen affects so many systems, its decline can cause hot flashes, night sweats, mood changes, anxiety or brain fog, vaginal dryness and bladder changes, bone thinning, and weight changes, and also increases your risk of heart disease and diabetes. So in short, estrogen is like the body's maintenance hormone, and it keeps many systems balanced during perimenopause and menopause. As estrogen production falls, those systems can start to feel the strain. So there's a big link between cholesterol and estrogen, and I think Lize also mentioned it or alluded to it previously in her talk about the hormones and how we make hormones. So all of our sex hormones, estrogen, progesterone, testosterone, are all made from cholesterol. Cholesterol is the building block of these hormones. The ovaries and later the adrenal glands and the fat tissue take cholesterol and they convert it step by step into estrogen. And this is also why a low-fat, high-carbohydrate diet can actually make hormone balance worse, especially when we start hitting our midlife and menopause. A high-fat, nutrient-dense ketogenic diet provides plenty of the raw materials, which are the cholesterol molecules and healthy fats that the body needs to keep making hormones after the ovaries slow down. So when insulin is high from eating lots of sugar, refined carbohydrates, the fat cells grow and they hold on to more estrogen, meaning that there's less in circulation. So less circulating estrogen that is available to act on the receptors, which also contribute towards the symptoms of perimenopause and menopause. And after menopause, the fat cells also produce a weaker form of estrogen called estrone. And if body fat is higher, especially around the tummy, these estrone levels may be too high relative to progesterone in the body, which can cause symptoms like breast tenderness, heavy bleeding in perimenopause, or even higher risk of estrogen-driven cancers. So the quality and the balance of estrogen matters, not just the total amount. So atypical mistakes that most women make when they're trying to be healthy is that we count calories instead of counting the nutrients of our food. We cut out fat instead of cutting out sugar. We do cardio training and no strength training. Skipping protein and losing muscle, ignoring our sleep and stress signals. We rely on willpower instead of habits. We expect quick results, and we don't get adequate help or support in our journeys. Women don't fail because they're weak. They fail because they've been given the wrong strategies. And the real solution is shifting to hormone-friendly, sustainable whole body health practices that match the stage of life that you're in. So what can you do now to fix your broken metabolism? We want to focus on nutrient-dense, whole foods and stable blood sugars. And I just want to add here, whole foods does not mean whole wheat foods, because a lot of people think that if they eat the whole wheat or the seed or the brown, that it's better for them. It has more fiber. We don't really need that. But in terms of carbohydrates, it's basically the same as eating the white bread or the white rice. So we mean whole foods as in foods in their whole form and how they would be found in nature. We have to include healthy fats daily into our diet and not be scared of fat. We have to prioritize strength training and resistance training, especially as we get as women get older, to maintain our bone density and muscle mass. We need to aim for protein at every meal and build sustainable habits instead of just trying to cling for quick fixes all the time. We have to treat sleep and stress reduction as medicine and prioritize those things in our life and not do other things and going to bed late all the time and putting our whole sleep schedule out of whack. We have to focus on our long-term health markers and not just the scale, and get support and accountability from those who are going through the same thing as you, or just someone who can help you, because it isn't always easy. While we can't stop menopause, we can change how we experience it, and diet is one of the strongest tools that we have. Menopause is a gift. Humans, orcas, and pilot whales are the only mammals that go through menopause. All our other mammals that we think we're similar to, like primates, they don't live past their reproductive years. And so they actually don't have a menopause. So menopause allows us to live beyond our reproductive years and contribute to the success and survival of the next generation. It is not an evolutionary flaw. Before we wrap up today, I want to make sure that you don't leave here feeling like you have to figure all of this out on your own. If you're looking for encouragement, resources, or a safe space to stay motivated, I'd love to invite you to join my Low Carb for Life community. It's completely free, and you'll get access to ongoing tips, weekly calls, and support from other women who are on the same journey as you. If you're looking for more personalized help, maybe you're struggling with stubborn weight, cravings, or hormone-related challenges, I also offer one-to-one metabolic health consultations where we can dig deeper into your specific needs and put together a plan that actually works for you. I'm going to share the links in the chat if you would like to know more, so that you can see what feels like the next best step for you, whether it's joining the community, booking a consult with either me or Dr. Lize, or both. We'd love to continue supporting you on your journey to health. So I'm going to share a few QR codes now that you're welcome to join. If you want to join our low carb group, this is the QR code. You can open up your WhatsApp and just scan that. It is completely free. There's people from all areas of life, some of my clients, some people that have joined, and it really is a supportive community of people that are using low carb diet to solve their medical problems or improve their health. And I think it's just so much easier to than going it alone. That was not meant to be there. And then we've got 5 minutes left. I'm aware of the time. Before we go, and you're welcome to ask questions. So you can still post them in the group, in the chat, and we will get to them, or you can unmute. But I wanted to just remind you about our competition. Our competition. So we did offer a competition to anyone who is watching tonight's webinar live. You can win a 60-minute metabolic health consultation, including a full body composition analysis with me, and also a free near dance class at any of the near dance classes around the country, in South Africa only. And we will do the draw this weekend, and the winner will be announced by email on Sunday. So what you need to do as well is follow us 3 on Instagram And then if you're attending tonight, your name will be entered into the draw to win. So here are the social media links for myself. The low carb occupational therapist, Nieuw-Metabolism is Dr. Lize's practice. And then NEA in Africa is some more information on the NEA dance classes in Africa. So I'll leave those on for a few minutes. You're welcome to scan them. I will also put all of these links in the chat in case you don't get a chance to do it now. And there will be a follow-up email probably following this webinar tomorrow or next week with all the links as well for you. And then I'm just going to head on to my last slide, which is the questions. And just to invite any questions, there are no stupid questions. We can all learn from each other. So if you're happy to stay on for a little bit, we can have a bit of a chat. You can ask some questions. Maybe say if you've tried something, what have you tried? Did it work or didn't it work? And we can just chat and get to know each other a little bit more and see how we can help you. I hope you enjoyed the webinar tonight, and thank you so much for joining us. Just want to try and see if I can now stop this. Are there any chats in the chat? Thank you.
I can't see any new questions. Anything curious? If we don't know, we'll get back to you guys. Thank you so much for informing. Recently down calls to improvement in my brain fog has been amazing. Yes, improvement in brain fog. Absolutely. You will actually notice the difference quite fast with that brain fog lifting. So I always tell patients also that, your goal might be for that kilogram to the kilos to leave your body and for the genes to sit better. But you need to appreciate all the improvements of the other subtle symptoms like brain fog, like energy levels, like clarity while you are, trying to do your work, and all of the headaches is a big one as well. And often sinuses, people struggle with sinuses chronically. They come back to me 4 months afterwards and like, oh, my sinus is cleared up. So those small wins are actually great signs that you are doing very well.
And if I can just add, Lize, in my experience with people that go low carb, it doesn't take a long time to see those, to start noticing those improvements. So within a week, I've had people tell me the anxiety has gone away. Their joint pain is so much better. They're sleeping much better within just 1 week of cutting out carbs.
Yes, absolutely. Absolutely. I think it's also the way you approach it. Like I mentioned in my presentation, I wouldn't necessarily tell everybody to go on a ketogenic diet, meaning aiming for ketosis, because if you were metabolically dysfunctional for quite some time, you probably have other factors of inflammation going on as well, which is not just diet orientated. And especially if you have something like an increased uric acid level, the acid that causes gout, that is usually excreted by the kidneys. And within that first few weeks of going into ketosis, your body actually gets rid of the ketones through the urine. So it has this competitive nature against the uric acid in your kidneys. And so in your blood, your uric acid levels raise. And then it can actually precipitate a gout attack, which would obviously be very inflammatory, very uncomfortable, and that can last for actually a few weeks on end. So a lot of times I would say in those type of cases where we possibly have more than one source of inflammation, to just take it slow, and rather have just a low carbohydrate diet, while we sort everything else out, and then we can always go over to a ketogenic diet in 6 months' time, and amplify the results that you are getting.
So Angela's asking, how do we balance the amount of healthy fat we eat and not being too high in calories and therefore gaining weight?
So I think that also depends on the timing of where you are in your journey. So we call it being fat adapted. So when you move from using glucose or glycogen as energy towards fat as energy, your body definitely has this adaptation time that it needs to go through. So when you go from a carbohydrate-rich diet to a high fat diet, you will feel what we typically would call a keto flu, because your body doesn't actually know how to use fat as energy. So when you get to the point where you're actually fat adapted and you're using fat for energy, you can really trust your internal cues in terms of your satiating, when you are satiated, because fat essentially is very satiating. So I usually say in the beginning, where fat has a role of satiating you and keeping cravings down, have a lot of fat. But as soon as you're over that first few weeks where the keto flu is kind of gone and your body is starting to realize that fat is energy, you can really trust your body's cues in terms of you will not overeat on saturated fat easily.
And also in the presence of low insulin, you're not going to store the fat. So you're not going to gain weight because you're eating a high fat diet. So it's actually the carbs and the sugar that make us gain weight, not the high fats. And then Abigail said she really struggles with not snacking after 8. It's like my body's telling me you'll starve to death if you don't eat. Any advice? Yeah, a lot of people struggle with that.
That's a difficult one. Yeah, snacking is always actually an emotional act, always. And that's why it can be so difficult to break these habits, because you need to understand how food and your relationship with food actually has an impact on your emotions. So I would rather say, in terms of, it's not a need, a nutritional need that you have after 8 to snack. Okay, it's an emotional one or a habitual need, and you need to go into to try and figure out why. Do you run for snacking after 8 p.m. in terms of your emotions? And usually when you can get to the core problem there, then you'll be able to break the habit, essentially. Snacking always is an emotional habit.
Yeah. And I think also switching to a higher fat diet leaves you feeling more satiated, and you're not going to feel that need. So a lot of those cravings and those constant thoughts of food disappear when we nourish ourselves more on fats. But there is an addictive element with sugar. So if it feels like you're going to starve to death, it could be that your brain is just telling you that, maybe there's also some addiction going on. Benita has a question for you. Fat is still difficult for her. Will her fat intake assist with decreasing her current high cholesterol? And she's currently on cholesterol medications as well.
Okay, so this is a topic of its own.
For another webinar.
Okay, so saturated fat will definitely not help in the sense of lowering your cholesterol, but cholesterol is not a problem on its own. It's not a problem per se. So cholesterol causes issues in the background of systemic inflammation. Okay, so you can have a cholesterol of 12. If you do not have systemic inflammation, it's not going to cause any issues. Okay, so the big thing is, what is your systemic inflammatory markers doing? Okay, are you insulin resistant in the background? How is your sleeping patterns? Do you have raised uric acid levels? What is your high sensitivity CRP doing? What I mentioned, maybe you have raised homocysteine levels. That's got to do with methylation and systemic inflammation as well. So if you have the background of systemic inflammation, then probably your cholesterol is causing you problems in terms of causing plaque in your arteries. Okay, and then when you're on a cholesterol medication, it's got two functions. It's to lower the number of cholesterol molecules, and also to, when there is plaque formation in your arteries, to stabilize that plaque, to kind of calcify it so it doesn't cause a rupture and an acute heart attack or stroke. So essentially what I usually do and advise is, assess the baseline systemic inflammation you are having. If you're having ample amount of inflammation, we need to sort that out before you will be able to get off of your statin safely. Okay. When you are, we sorted out your inflammation, which can take time. When we sorted out your inflammation, it would be safe to stop the statin. And we are fortunate enough to have some laboratories to help us aid in helping us in doing actually a cholesterol subfraction test, meaning we can go and test all the different types of cholesterol, which is more than just what the normal Ampath Lancet does. And we can quantify how much of the cholesterol that you are having is actually bad and deleterious. And if it's less than 20% of your total cholesterol, you really are low risk for cardiovascular disease long term. And then you can walk around with a higher cholesterol level without it affecting your health. We just need to make sure that you are metabolically sorted and metabolically healthy, and that you can come off of those medications safely.
So again, it's about insulin. So in a low insulin environment, cholesterol is perfectly fine. Yeah. Erica says that she's been LCHF for over 8 years now, and she's had 3 healthy babies. I feel better, stronger, and sharper at 40 than she did at 25. I'm at a healthy weight without any effort and boundless energy. I would never go back to a higher carb lifestyle, and she can absolutely vouch for a low carb or almost no carb lifestyle. And I agree with you, Erica. I also feel so much better now in my 40s than I did in my 20s as well. Audrey, I don't know what you would. LA triggers driving. That is omega-6, omega-3 levels as high as 80 to 1. And then she's listed a few different foods there. And basically that we need to promote the microbiome and also look at gut health. And Abigail gave us a thank you. All right, so I just want to say again, if that's it with everyone, thank you so much for joining us tonight. We will, the webinar has been recorded, so you will have access to watch it again or at a later stage if you want to. Or if you didn't make it live tonight, you can always get access to it again. Thank you for your time in watching, and I hope that you all learned something new. Please feel free to reach out to one of us if you do have any other questions or if you want a consultation. And yeah, Lize, thanks again so much. And I hope that with both of us, it can be quite lonely sometimes in the medical world with saying things that are out of the norm that not everyone always agrees with, but we know that there is science that backs up everything that we say, and that really to become healthy and not need medication and to improve your own health, take ownership of your own health is really the way to go. So yeah.
No, absolutely. Yes, absolutely. No, thank you for having my back as well. We can really have multiple of these sessions in the future and really try and promote health and healthy lifestyles for our patients.
All right, I'm going to end it there. Good night, everybody, and thanks so much for joining us.